Okay, hello and welcome everyone, and thank you for dialing in to our webinar today. My name is Justina Jenko. I'm the Deputy Director of EuroPris, and today I will be moderating this webinar. Most of you might know EuroPris. We are a network organization uniting different prison services in Europe. We have currently 41 member jurisdictions. And last year we gained 4 to 5, so it was nice to see that whole Europe is becoming more and more and entering the EuroPris family. We are organizing different events for prison professionals, physical ones, but as well as currently an online one like webinars. We are coordinating expert groups, bringing different experts from the different regions of Europe together. We have also a Prison Achievement Award highlighting different initiatives in Europe, and we have different tools to bring members closer together, like our KMS tool and EPIS tool, for example. But today, today's webinar focuses on critical and often overlooked issues. It is the infectious diseases in prison settings. And prisons are unique and often, these overlooked environments when it comes to public health, and elements such as population density, limited resources, and complex health needs creates the conditions, sometimes for difficult situations as infectious diseases, to spread. At the same time, people in prison have the same right to health as anyone in the community. And today we'll explore how prison services and healthcare professionals are tackling these challenges, from prevention and harm reduction to improving access to treatment and strengthening also the coordination with public health systems, but also management of infectious diseases such as HIV, hepatitis, and other with prison and detention systems. So we will learn how different countries and institutions are addressing this topic, which I'm very much looking forward to. We are very fortunate and pleased to be joined by a diverse panel of experts today and practitioners from across Europe, representing key sectors: prison services, healthcare, probation, and public administration, and also who bring knowledge and hands-on experience in this field. So this webinar will explore initiatives from Portugal, Luxembourg, and Ukraine, and experts will share their insights. Soon you will be introduced to each one of them. But first, I'd like to thank all of you for being here. You are our audience today, and this includes participants from a wide range of backgrounds: academia, prison, probation services, policy, and healthcare departments, as well as students. Finally, I would like to acknowledge also our team to support Zoom and this webinar today, our co-host. So this is Roxana Fargas, our intern in EuroPris, and Brody Bavic, our comms manager from the EuroPris team, and they'll be supporting in the back. So without further ado, let's dive in and start the conversation. Before that, a small housekeeping announcement. You are asked to rename yourself. You can do that by clicking on the 3 dots next to your name. So please add your full name or as well your country, so we know where you are from. At the same time, regarding the Q&A question box for your question, please use that. You can see that below in the Zoom, let's say, screen. Please be aware that the chat is disabled for attendees, but all your questions during the webinar, especially also when you hear the presentation, feel free to mention them via the Q&A box. And When it comes to the part where we would like to discuss a bit and ask and allow some more questions, I will be selecting the questions together with my team, so they will be addressed. Then they will be put live for you also to see, and then you know that this question was already addressed. So we are really looking forward to a lively discussion, and also for you, our audience, to come up with questions and some discussion points. So that will come later. Another announcement is that the webinar will be recorded, and we will make it available on the EuroPris event page after the session, and also inform you via email about that. Okay, let's move on now to our panel, to our experts. I'm looking forward to that part. So today we are joined by Linda Montanari. She's a health sociologist working as a principal scientist at the European Union Drugs Agency, where she coordinates work in various areas, including prison, gender, and mental health. She coordinates a network of European experts on prison and drugs, and recently she has been working in coordination with the ECDC on the publication of a toolkit for the elimination of hepatitis in prison. Very welcome, and thanks that you are with us today. Also, I would like to welcome Dr. Cornelia Berger from the Medical Service of the Prison Administration in Luxembourg. She's specialized in general medicine and emergency medicine. She's a member of a medical team working in 2 of the 3 prison facilities in the country, and she's involved in the daily health care of detainees, focusing on prevention and care. And finally, we have a presentation from Ukraine. Very welcome. Dr. Yaroslav Basarab, Director of the Center for Healthcare, State Criminal Execution Service of Ukraine. He oversees strategic planning and operational management of penitentiary healthcare across Ukraine. He focuses on enhancing healthcare standards and integrating international best practices. His expertise is the management of infectious diseases, harm reduction programs, and implementation of innovative healthcare interventions. And also from Ukraine, we have Dr. Pavlo Marshenko, Head of Department for Organizational and Analytical Methodological Support at the Center for Healthcare, State Criminal Executive Service of Ukraine. He's responsible for coordinating the implementation of healthcare standards and digital tools across penitentiary medical facilities, with a focus on improving access to HIV, TB, and substitution of therapy services. So now let's move on to Linda Montanari. You will focus today on infectious diseases in prison, and beginning with a general overview of drug use and injecting drug use among prison populations. And furthermore, you will present us today a recent initiative currently being finalized, this toolkit I mentioned for the elimination of hepatitis in prisons, also developed with the ECDC. Linda Montanari, I'm happy that you are with us today. The floor is yours.
Thank you, Justina, and thank you, EuroPris, for this invitation. I think it's very important for people like me working in the area of prison and drugs to be connected with your network, because it's an important network related to the prison administration. And good afternoon to everyone who is connected. I will share my presentation now. Just a second. Can you see it? Yes? Mm-hmm. Okay. So as Justina was saying, I will talk about infectious diseases in European prison, the challenges and the possible intervention. And this presentation will prepare together with my colleague Thomas Saylor, who is responsible for drug-related infectious diseases, not just in prison, but in general among people who use drugs. So first of all, I think it's an important information you know. So there were, according to the latest space of the Council of Europe statistics, around 800,000 people living in prison in the countries that are reporting to us, to our agency, which are the 27 member states plus Norway and Turkey. And on average, 18% were in prison for offenses against the drug law. But the connection between drugs and prison is important, so that's I want to start from there. So because there are different groups, there are not just people who are in prison for offenses against the drug law, and now we are starting also to try to understand and to distinguish between those in prison for drug use and those in prison for drug trafficking. But there are also people who are in prison for offenses that are committed to support the drug use, for instance, the property crime, the so-called acquisitive crime, and that's concerning a lot also, you probably know, women in particular, but many people that are in prison. And finally, there are people who are in prison using drugs or with problems related to the drug use, who are in prison for other type of offenses. Another important contextual information is that many people are in prison for quite some short sentences, which is relevant, especially if you think about infectious diseases and the spread of infectious diseases. And there is a high recidivism rate, especially among most problematic drug users. One thing that is important also to consider when we look at the relation between drugs and prison is the fact that we don't talk about drug use in prison only, but drugs and prison, because many people who are entering prison have experience with drug use, and these graphs show this information. So with the graph on the left showing the lifetime prevalence of illicit drug use before imprisonment in different countries, both in the prison population, the violet bars, and the green one in the general population. And as you can see, there is a huge gap in all countries between the two, with much lower level in the general population compared to the prison population. Also, if we look at the table on the right, it is reported the maximum prevalence value for the prison population, the general population, for some selected illicit drugs. And as you can see, there are prevalence is particularly high when we look at substances like amphetamines or heroin, or even cocaine, so where there is many more times higher the prevalence in the prison population compared to the general population. However, if this was referring to the drug use before imprisonment, drugs are used also inside prison, even if several people stop using drugs when they enter prison. So some continue, some change the drug use pattern. And referring to infectious diseases, is important to consider that there is also sometimes we don't have the quantification, at least at European level, but the change from to inject drugs, because it is a modality to use drugs which is more effective. But since then the equipment in prison are very scarce for injecting drugs, this may lead to increase the risk of infectious diseases because of the sharing of injecting equipment. More recently, let's say since already more than 10 years, there were the appearance of use of new psychoactive substances in prison, and we conducted a study on these in 2018, where 22 out of 29 countries were reporting some sign. We didn't have quantitative data of use of these substances. More recently, there was some indication of use of synthetic opioids, particularly nitazene, in some countries, even if in some cases that was not confirmed by the toxicological analysis like in Ireland. But is an issue that we should consider. And in some cases, like the synthetic catinone, the prevalence is low, what is reported, but again, they may be injected more easily than the other substances. Then just trying to move towards the topic of today's webinar, I think it's important also to have like contextual information on the fact that there is a high burden of disease in general in the prison population, because they have high level of social economic determinants of health and poorer health than the people in the general population. They have a higher rate of obesity, cardiovascular disease, cancer, mental health problem. We have conducted studies and collecting data on comorbidity of mental health and drug use, and there are levels that range arrive up to 90%, and of course infectious diseases. What I reported here in the left is the latest status report on prison health in the WHO European region, and I think a new publication will be published in probably coming months on the health status of the people who are in prison. The risk factor for non-communicable diseases include high rate of smoking. We know that there are up to now 80-90% of people who smoke. Among the people who are in prison, some starting smoking as well, the poor diet, insufficient physical activity, relapse to health risk behavior such as substance use and harmful use of alcohol, and for communicable diseases, injecting drug use, unprotected sexual activity, and unsterile piercing and unsterile tattooing are risk factor for transmitting communicable diseases. Another big issue that I would like to mention is the mortality that is both high, both inside prison and after prison release. Inside prison also the drug component is important because there is many suicides and a lot of many violent deaths. This is the result of a research conducted in France, reporting that 1 in 10 of these 78% deaths were due to intentional or accidental drug overdose and intoxication. And then the mortality after prison release, we know that the first 2 weeks after release is very risky for drugs overdose, but is also very risky for infection, so for drug-related infection. And that should be another thing that should be considered. So looking at the drug-related infectious diseases, I'm looking at the HIV, HCV, and HBV. And here you have some data in the general population and in studies, in national studies conducted among people who are injecting drugs. This is the abbreviation of PUID. And as you can see, it's not necessary to go into the detail, but there is a huge gap between the prevalence reported in the general population of both the three drug-related infectious diseases and those reported on people who are injecting drugs, with particularly high level among HCV. Even these are all the infection, not the active infection, so it's referring also to past infection. Of course, there are limitations on these studies, but I think the main message is we have a problem in this population regarding drug-related infectious diseases. These are recent trends in general among people who are injecting drugs. As you can see, from 2009 to 2023, the new HIV notification decreased, and they were always below the target of UNAIDS. But there are some outbreaks that were reported, and here is the map showing some of these outbreaks of HIV cases reported in different cities, more not at national level, and there are many of them, they are related to the injection of stimulants. You can see from the different colors, so the blue are synthetic catechinones, which are also stimulants, amphetamine, buprenorphine, and cocaine, or cocaine and the heroin. Just in Lithuania, there is in prison, there was an outbreak of HIV due to the use of opioids, and I will refer to this also later. This is, as I say, in general, these data refer to the prevalence of HIV and HCV and HBV in the prison population. And if you remember the data from the general population, so this confirmed that this is more or less the data that is reported among the people who inject drugs, so with very high level of prevalence, and this is all the prison population. We have less data on those who are in prison and have an history of drug injection, and in this case, the prevalence level are even higher. But as you can see, we go from 0 to up to 12% for HIV, up to more than 40% for HCV, which is the higher, and up to 15% for HPV. The variations between the countries, because I imagine this would raise a lot of questions, but are related to different factors, including the different patterns of drug use in the population, the history of the drug epidemic in the different countries, as I said before, also the level of harm reduction services that are imprisoned, and also, of course, methodological issue and lack of quality in some cases of the data, which is an issue on which we try to work. This is a study that was conducted by my colleague Lucas Wissing together with a group of experts, showing that there is an association between prior prison history and HIV and HCV infection among people who inject drugs in Europe. Studies conducted between 2006 and 2015 among people who were in drug services and had a history of incarceration. And as you can see, again, the odds ratio is over above 4 for HIV compared to those who didn't have a prison history, and above 8 for those, around 8 for HCV, compared to those who didn't have prison history. How to interpret this data is not just that prison can be a risky context, but maybe also the most vulnerable also go to prison, and might be also other reason and other motivation that we can discuss later. I said before, there is drug use inside prison, and there is also drug injecting. These are the countries that were reporting data, the latest data available from 2020 to 2023. As you can see, in all cases except Cyprus, but the numbers are, of course, are very low. In this case, report that there is some drug injection inside prison. This is lifetime prevalence of drug injecting. In the other cases, the level are lower than the level of drug injecting before imprisonment, but there are, and this is something that I think somebody working in prison from the prison administration should really consider from a public health perspective, because it's really a risky behavior, especially in view of the fact that there is a scarcity of substances and scarcity of material for injection. So the incidence, there is very little data on incidence. I don't know if there is anyone from Lithuania. This is something, a graph that we publish with the text in our prison and drugs report published in 2022, showing that in 2016 and 17, there was a higher rate of new HIV infections in prison reported in Lithuania, with more than 20% of the total number of HIV positive people in prison having contracted the infection inside prison. We know that after this outbreak in Lithuania, they introduced the opioid agonist treatment as type of treatment for people with drug-related problems, and that was a big change, an important change, and led to a decrease in infection. Also, is it possible, as Lithuania has shown, but also these are two cases, and I'm glad that Dr. Cornelia Berger is here, in Luxembourg and Madrid. Madrid was in the community where, as you can see, there was a decrease in the HCV active infections from 2017 to 2013. You can look at the red line. And in Luxembourg, also you can look at the red line, especially the dot one, indicating the current infection. You could see that there was a decrease. And this decrease seems to be mainly related to the implementation of harm reduction intervention targeting the infectious disease in prison. You can have more data in this viral hepatitis elimination barometer that you can find in our website. So what is done inside prison? Stop me, Justina, if I'm taking too long time. This is an overview of available drug-related intervention in prison in the countries that are reported to us. This indicate whether the intervention is available. It can be one prison, it can be all prison, whether it's not available. And as you can see, especially when we look at drug-related infectious diseases, or we can look at some intervention that is addressing in some way also infectious diseases. We have testing for infectious diseases in basically all countries, OIT also in all countries except Slovakia, which is still the only country among those reporting to us not having officially implemented OIT in prison. But then there are some interventions that are available in only few countries. So like Netherlands Siege program, we know it's available only Spain, Luxembourg, and one prison in Germany. Naloxone distribution is available in 6 countries. Distribution of disinfectant, but also, as you can see, HIV prophylaxis, HPV treatment, or vaccination, they are not available in all countries. Also, as I said before, that means that these interventions are available officially, but doesn't mean that the coverage is concerning all prison, or even more, all people who are living in prison. In the map, you can see the HCV testing coverage in prison, where you can see that, first of all, there is very little data. Secondly, the level of coverage is data from 2019, so it's a bit old, but the coverage was scarce. Now it has improved a little bit, but still not sufficiently. And also there is an issue concerning all type of intervention of the delay in introducing this type of intervention in prison. In the line, in the graph on the left, you can see the yellow line is the opioid substitution treatment, the year of introduction in the different countries in the community, and the green one is in prison, where you can see there is a delay of almost 20 years between the two. And so that's something that probably should be considered, especially by the prison administration. What are the reasons for these barriers? Here is more, I won't enter into the detail, but just you can see for some harm reduction intervention, where they are available, where according to what is reported to us, we have a network of national focal points, which are our partner, reporting data at national level. So there are some interventions that are available in almost all countries, as you can see, and some that are basically, as I said before, not available, or on which it is not known whether they are available or not. And that is very important, especially for infectious diseases, as I say, HIV prophylaxis, NSP, and vaccination for hepatitis, etc. Another issue that is really important for infectious disease is the linkage to external care. And if we look at the infectious diseases part, but also the social care is important, there are still 8 countries that say don't have any linkage to HCV care outside prison, or HA5 don't have any linkage to HIV care. And we know that not having linkage with the community may lead to interrupt the treatment or get reinfected, and of course made me also getting at risk for other behavior. And as Justina was announcing before, we are finalizing, and hopefully we will publish soon a toolkit for prison staff for the elimination of hepatitis in prison. This is done in coordination with the CDC, with the main author is staff of the CDC. But was done with a lot of stakeholders, including EuroPris. We established at the beginning an advisory board that was consulted at different stages, and I think that was really important to have a more practical view on what should be done. this toolkit is divided in 4 parts, as you can see. The background, a background chapter with information on the reason why we should eliminate hepatitis in prison, why is important, the data on the epidemiology of infectious disease, on hepatitis B and C. In prison, and there are also a lot of material in all these toolkit. Then the strategy development, the strategy implementation, and monitoring and evaluation. And as I say, there is a lot of material in this toolkit, like frequently asked question on basic information like what is hepatitis, what are the consequences of hepatitis, or for instance, what is microelimination, and other, very questions that may come up. There are also call-out content. We try to, put in evidence some content that is important to consider when you want to eliminate or to decrease hepatitis in prison, some case studies, some references, templates for different like data collection or mapping of the situation. Well, just briefly go not into the detail, you can have all the slides, but as I say, so the first one is the elimination of the background information on the elimination of viral hepatitis in prison, where we try to respond to all these questions, as I said before. There are fact sheets and also policy brief and link to other toolkit in some case study. The second part is the strategy development, where we indicate to provide an overview of the policy framework, advice of having a person-centered care, and then a really step-by-step practical guide on what you have to do in your prison to develop a strategy to address the hepatitis and to eliminate hepatitis in prison. First of all, identify the key stakeholder, because the key stakeholder are the essential to have good connection, to have them involved and at different level, from the healthcare staff to the custodial staff, but also the people living in prison, any peer organization and external service of the community. Then conducting a health needs assessment, because you have to see what are the needs of your population, what kind of population you have. So like if it's sentence or short sentences, if you have migrants inside, so that has different implication also for the health intervention provision, developing a strategy, creating targets and monitoring progress, and then of course an eye on the financing. Then the strategy implementation, where we focus on some also practicalities on prevention, where we indicate some core intervention for prevention, including harm reduction, some also key indication regarding testing, with also the presentation of different type of modality for testing, like the opt-out options, the rapid testing, then the treatment, and what you have to do for the post-release. We give also a specific attention to some groups, like women, youth, foreign national, and for every, in all this part, there is also like some table where we present what can be the challenges and what can be the solution. Finally, there is a session on monitoring, because you see this is really important. And we also have defined, and that was before the toolkit, we integrated in the toolkit as UDA four models of care that are not reflecting any comprehensive analysis of what is the best practice, but they are just models that we get to know, and they have a different focus. One is in Milano, one in Berlin is the only women prison we have among these 5 models. So in Luxembourg, in Ocana in Madrid, and Montpellier. So they are highly innovative. They were quite highly effective, these models, because in some cases they manage to eliminate the hepatitis in prison and can be transferred because there are, again, very practical information on them. Here, just to show you the models of Montpellier that is focusing on continuity of care and was defined because there were many people that were interrupting treatment or discontinuing after release, or some groups, as I said before, like migrants that were not able to access treatment. So it was then defined a model where that was based on the person, on an assessment on the person, on the multidisciplinary approach where the nurse, the pharmacist, the doctor inside prison, but also the services outside prison are linked in order not to lose the patient along the process of treatment and also to prevent reinfection. And it was quite successful. As you can see, there were also indication of some barriers, like the fact that the DAA's treatment was not possible to be prescribed except from the hospital setting, but then since 2017, this was extended, and so that's improved the coverage of treatment. Finally, we have one thing that I think is really important is to conduct training. That's already presented, and we hope to launch this training soon, where there is also one section on infectious diseases and one will be related to the toolkit. So to really finish, so we just 3-4 messages. One is that people who use drugs are overrepresented in prison and they present a high burden of physical and mental disorder. Drug-related infectious diseases are also highly prevalent among the prison population. So it's necessary to intervene on these by increasing the availability of health and social intervention, considering also that two principles, so the equivalence and continuity of care, that is established by the UN document, the Nelson Mandela Rule, and considering that if we intervene on this population, we don't intervene just on this population, but on the community as a whole, because prison health is public health. So I would like to to give particular acknowledgement to my colleague from ECDC, Erika Duffel, who was coordinating this project together with the other colleagues, the advisory group, and the person who were in charge of the different models of care. Thank you very much, and you will find more resources in our website, or you can contact me if needed, but we can also discuss later. Thank you.
Thank you, Linda. Very informative presentation. You mentioned a lot of things. Right away would like to start with a discussion, but I leave all the questions for the audience now. Feel free to type them in the Q&A box. Thanks, Linda, again. You mentioned a lot of things, the high burden of diseases and the status report as well from the WHO, the risk factors, the mortality, the prevalence, very interesting. And also for us in the prison sector, the toolkit and some interventions which are already there by the countries. So I think it was very informative and insightful. And I would like to thank you and now give the floor to our next speaker, Dr. Cornelia Berger, and you will be presenting about Luxembourg's approach to screening and treating infectious diseases in prisons, highlighting some key interventions that have been implemented in the results. So I'm looking forward to this presentation now. Dr. Cornelia Berger, the floor is yours. Thank you.
Thank you very much, Justina. Thank you for the invitation and the option to speak to you today and present our daily business, as already a little shown by Linda. And we'll definitely see the chart Linda had chosen from Luxembourg again in my presentation, which I'm just about to get started for you. Here we go. Should be fine. So, yeah, I'm speaking to you today about interventions and results from our daily prison screening and treatment for infectious diseases in Luxembourg. For the start, probably most of you are not up to date with our infrastructure. So in Luxembourg, we have 3 prisons, the Centre Pénitentiaire de Luxembourg, which is the largest prison with women and men finally convicted, and all women in Luxembourg, because it's the only institution taking care of women. We have a maximum of 443 detainees in our institution there, of which round about 75% are of foreign origin. Besides that, we have another semi-open panel system prison for 113 detainees outside in the countryside, as you can see on the photo below. And from 2022, November 2022 on, a new prison had been opened in the south of Luxembourg City, the Centre Pénitentiaire d'Osterhof, for a maximum of 400 detainees, but all there in remand in custody. When they've been finally convicted, they are all transferred to the main prison in Trussig. So these are the 3 main institutions. My service and me, we are taking care of these 2 main institutions. As in Luxembourg, the medical service, the prison medical service, is provided by an external hospital service. It's a different service for the prison Osterhof, the new one for detainees in remand. So at the moment, for these roundabout 600 detainees in Luxembourg, we have 2 services: the prison medical service in service 24/7 hours. It's a 3-shift model, which provides a 24/7 system. Besides that, we have a strictly separated prison psychiatric service, also provided externally, which is in charge at daytime, 6 a.m., 9:30 p.m. Night times, our service from the medical service provides also psychiatrist on-call service. At the moment, we are 3.5 general practitioners, FTE, full of total, which would be 40 hours per week, and 18.25 due to part-time work nurses for our service. We do have a consultant in infectiology doing hours in our institution twice per month, but of course we're discussing almost daily cases as needed, as questioned. We are doing a systematic screening on admission with all admissions in our service in opt-out mode, as Linda had mentioned before. We do a general blood test at admission and chest X-ray. The blood test covers also, beside a health screening, kidney parameters, all the standards. For infectious diseases, we cover a quantiferon test since 2011, and we're also testing for syphilis, hepatitis A, B, and C, HIV, and varicella. Besides that, that's a standard. Yeah. So early interventions in our service for infectious diseases. Since 2003, we're doing this systematic screening, as mentioned before, and along the results, vaccination on admission. Every patient in our institution gets a quick health checkup by a nurse immediately at admission and by one of the general practitioners within 24 hours, even at weekends. Yeah, as our service is 24/7, everybody is seen at admission by a nurse and within 24 hours by one of the general practitioners, as well as by the psychiatric service. Since 2005, regarding early interventions, we offer a syringe exchange program in our prison. As Linda had also shown, many prisons are not drug-free, so we have to have a realistic approach. From 2012 to 2019, we used to do an annual screening campaign using point-of-care tests. And from 2003 to 2015, we already did an early switch to treatment with direct-acting antiviral drugs for hepatitis C. So we try to treat all positive diagnosed patients in hepatitis C, if anyhow possible, during their stay in our prison. Thanks to our prison administration and ministries, the coverage is assured, but of course, we'll mention this later on again, the stay or the time of stay in our institutions is a big factor in a sufficient and positive hepatitis C treatment. Short stay is always a problem regarding this aspect. Since 2014, we started to do an annual follow-up in those people known for infectious diseases, treated for infectious diseases, and known for injections for drug abuse or continuing with their drug abuse by injections. Since 2016, we've very much improved the access to a needle exchange program also outside prison, especially in Luxembourg City. And of course, we try to keep and stay in touch with institutions covering our patients also outside the prisons. Since 2017, we've started a Safe Tattoo program in our infirmary. So we have a specially qualified nurse for hygiene and aspects in tattoo, and we offer our patients to get them self-tattooed. Some do it themselves, some get some other to do it. We offer them the machine and the ink and everything under supervision by a trained nurse, also to prevent infectious diseases due to unofficial tattooing. And since 2024, we've been starting treating with injectable HIV treatments also in our prison. So here we've got some pictures. On the left, you can see the room where our Safe Tattoo program is held. Of course, we also offer condom distribution. We have here on the right some pictures of our syringe exchange program. So, and there is the chart we've seen with Linda before regarding our results from our screening on infectious diseases in Luxembourg. So this shows from 2010 to 2021. This is due to, because as I've told before, the new prison for all the detainees in remand had been opened in 2022. Before, all these had been located at our institutions as well, had been transferred to the new prison end of 2022. And the results from there, which are also covered by the same infectiologist, need still to be included, because now we're talking about two different medical services, for infrastructure. At the bottom line, you can see these big steps in our treatments, as mentioned before. On the top, you can see our total screening parameters per year, all detainees screened on admission. And as told before, for hepatitis A, actually, we're screening for vaccination status, because if the vaccination status is negative, we offer the vaccination against hepatitis A. But there we can already also see a nice decrease within these 11 years. Then, as told before, since 2011, we've been screening for quantiferon tuberculosis, and I'll refer to that again on my next page. We see slight decreases, slight positive tendency. The line Linda had been referring to before, we're very proud of, is the hepatitis C serology at admission. As told before, we screen in an opt-out mode all admissions for hepatitis C, and if hepatitis C should be diagnosed or reinfections on readmissions, we offer the patients to see the infectiologist for all the examinations still necessary, and if possible, we offer treatment to all. Yeah, very positive tendency there too. Also, we screen for hepatitis B, and same as with hepatitis A, we offer, in case of non-protection, the vaccination, or in case of a hepatitis B infection, the patients are offered to see the infectiologist for treatment if necessary. So the hepatitis C screening for virusless is the next chart. So the two lines for hepatitis C are the red lines with the same positive tendency. In HIV serology, the same procedure with us. We screen them and we offer treatment and infectiological follow-ups. It's no big change regarding the numbers for HIV, especially in younger people. We see no big change in the numbers. And the last one to screen with us is syphilis, and also the same regarding with syphilis. The numbers don't really change. We're still discussing this later on. One special point of interest for us is also tuberculosis in prison. So within 11 years, from 2011 to 2022, we've had 19 tuberculoses treated in our prisons. 8 of them were sputum positive, which means contagious, and 4 of them had been diagnosed for tuberculosis before in prison, which meant we had to do follow-ups and treat all contact persons as well. We had latent tuberculosis on admission since 2011, 27% with a quantiferon above 0.4, which is the level for us for a positive quantiferon test. And these had in 10% were even above 1 international unit per milliliter. Regarding this, in Luxembourg, since 2024, we have changed to treatment recommended for all inmates younger than 40 years old and with a quantiferon above 1 unit per milliliter, and offer this treatment to all patients. Same system, equivalent as outside prisons in Luxembourg. So that's a Luxembourg-wide recommendation from 2024, of course, adapted in our institutions as well. As mentioned before, a big challenge for this 3 to 6 month treatment is the short stay period. So it's very difficult for the patients, on the one hand, to complete the treatment if they leave our institution, and of course the explanation. So when somebody has no symptoms or maybe even has problems to understand the the disease itself and the risk factors for himself and his surrounding, it's very difficult also with cultural backgrounds to explain to these patients why they should take several months, multiple pills if they do not feel sick. Yeah, that's a sentence I can hear very, very often in my consultation regarding this point. Yeah. Conclusions. Yeah. So screening at ours in these 11 years between 2010 and 21 could be done in between 79 up to 94% of all patients. Of course, it's opt out, and we're still fighting patients refusing blood checks. Also, as mentioned before, for some cultural, religious reasons. We always try to see them 3 times to offer and discuss the indication and the necessity for the blood check again, to explain to them the positive effects for themselves, for the surrounding, for their families, not to get them sick. So up to 3 times we try to meet them if they refuse the screening on admission. In 2024, we only had 65%, but as mentioned before, we do not get all patients at first admission to our institutions anymore. If they go to the new prison in Osterhof until finally convicted, they'll be screened there. So these screenings do not appear in my charts here. They should have to be added on. For the reinfection rate at readmission for hepatitis C, we could see that around about 110 per 1,000 patient years were reinfected, which means around about one patient per year in 10 patients known for treated hepatitis C were reinfected. Yeah. We found out, we think that an effective package for risk reduction of infectious diseases in detainees is to offer them the access to treatment and their surveillance. Of course, not only inside prison, because they're in a very protective environment at ours, but also outside prison. We need very good team skills and members taking care of the patients as well inside prisons, general practitioners, nurses, psychological service, psychiatric service, drug addiction help program service inside our institution, but also outside, especially regarding follow-up and completing treatment if begun in our institution. Because of course many patients have no health insurance, so we have to arrange and take care that they can't even complete their treatment outside prison if they're not taken care of in the national health insurance system, or as mentioned before, because we have up to 75% patients from foreign origin, it's also a big problem if any treatment had been started in our institution and they leave the prison and they're leaving the country. Very often the treatments are probably not completed. Even so, we try to explain and help them to get it arranged or done. Yeah, and we're very proud that one of our prisons, the main prison in Schleswig, is almost hepatitis C free in 2024. So as you can see, we're still working on it, and that's our big aim to achieve. So, and the key message is from Luxembourg is the teamwork, as mentioned before, the teamwork among professionals is a main factor to us. So we're doing programs with our nurses, with our teams. We know it's very important as well for the medical service, but also all the other services included in a prison to work hand in hand, to go along with each other, to have the same goal, to achieve the same goal. As mentioned before, prison health is public health. That's a big aim for us too, because we know we can prevent a lot of problems outside prison by treating our detainees. And as mentioned before, that's one of my main aims, is prevention, screening also. Many of our patients, some haven't ever seen a doctor before in their life. They have no contact with any medical service. They cannot afford it. They didn't get the opportunity. So very often we're the first medical contact as well. And it takes time and knowledge and patience to explain the need and the possibilities of health service. Yeah. And thereby we try to form the trust in healthcare for prisoners. And this all, as mentioned before, 3 times to explain the indication of a blood check takes a lot of time too, which is nowadays not always easy. The confidentiality from health towards the judiciary, of course, helps a lot to do all our work, and the numbers, the charge, the results from our programs, and also all the fantastic things Linda had shown before. The epidemiology should and must guide the healthcare informations, the interventions, and to decide what is necessary, what is justified, or even change existing procedures and recommendations. Yeah, thank you very much for your attention. These are the email addresses of me and my chief consultant for the medical service in Luxembourg, Philip Poes, and our chief infectiologist, Pierre Braquet, who both had helped and brought together with me this presentation. And in case of any further questions following this webinar today, feel free to contact us. We're happy to answer them. Thank you very much for your attention.
Thank you a lot, Dr. Berger. It was very interesting to see. And actually, I've been to the new prison you opened, so it was interesting even in this context. And for showing the audience your early interventions and also what you do in Luxembourg, the total number also of screening per year. Very, very interesting. And what you mentioned regarding the tuberculosis as well. I know there's here also, as it seems in this area, in the health area, a challenge you mentioned more, but especially that I know often it's like 2/3 or 3/4 of the whole prison population is actually short-term prisoners. So then, of course, you have your challenges regarding this also in this area, which I understand, and also what you mentioned, the cultural and foreign nationals maybe background. So very, very interesting. Thanks for your presentation. Again, the audience is now invited to share some more questions via the Q&A box. After all 3 presentations, we will move on with the Q&A session. And now let me introduce, or I introduced already, but let me give the floor to Dr. Pavlo Marchenko. I've introduced your director and colleague, Dr. Yaroslav, and you'll explain. I heard that he can't be with us last minute. So you'll be presenting the harm reduction program in the Ukrainian penitentiary system in the relation to infectious diseases. And also, I know you were shortlisted candidates in Ukraine regarding a project for our Prison Achievement Award last year. So Dr. Pavlo Marchenko, the floor is yours, and looking forward to hear from you.
Yes, do you see the presentation? Yep.
Yeah, we can see it.
Great. Colleague greetings. It's a pleasure to share an update of comprehensive harm reduction approach implemented in Ukrainian penitentiary system. Before I begin, I would like also to note that in 2024, one of our pilot initiatives focused on person-centered harm reduction services in Odessa Correctional Colony number 14 was shortlisted for EuroPris Prison Achievement Award, and this recognition from the international community has been a strong motivation for our continued work in this area. Today, I will outline key developments, current practice, and lessons that we learned from our implementation efforts. In recent years, harm reduction programs have been implemented in Ukrainian prisons. I'm talking about OST, syringe exchange programs. And these interventions, they not only mitigate health risk, such as reducing the transmission of HIV, hepatitis B, C among people who inject drugs, but also function as a strategic component of systemic efforts to combat drug trafficking within penitentiary institutions. And these programs help to prevent overdose cases and stabilize the condition of individuals with substance use disorders, which in turn reduces conflict levels among inmates, improve behavioral control within penitentiary facilities, and decrease prisoners' reliance on non-formal drug sources, which often tied to internal criminal networks, debt relations, violence, and those harm reduction programs are not only as a medical intervention, but also as tool for stabilizing penitentiary environment and enhancing institutional safety. Before I move to the specifics, I also want to briefly show you the strategic context in which all of this program fits. Because we are not just responding to individual challenges, we are acting within clearly defined national strategy. At the national level, Ukraine has adopted the penitentiary system reform strategy, which clearly defines the following strategic objectives. It's about ensuring counteraction to spread of high impact infectious diseases among convicts and persons taken into the custody, and providing quality medical care to persons in custody and convicts with mental and behavioral disorders, including those resulting from the use of psychoactive substances. And this is exactly what we are implementing falls under. It's about OST, needle exchange programs. Looking ahead, the Ukraine aims to align with countries that have successfully implemented scientifically validated models such as therapeutic community. And also, I want to add that we act in compliance with national HIV strategy until 2030, which explicitly provides for the following implementation of OST and harm reduction programs in penitentiary institutions, resocialization for people living with HIV, increased access to evidence-based interventions in place of detention. According to CPT recommendations, with our resistance in the beginning of 2025 year, all healthcare facilities in penitentiary system established the position of clinical psychologist. This was an important step toward enhancing a multidisciplinary approach to working with people with mental and behavioral disorders, including addictions. Moving next, In implementation of all of these programs, we learned that comprehensive response is very important, and we identify three interconnected areas of comprehensive response. It's opioid substitution therapy, which provides stabilization of physical conditions, reduction of HIV, hepatitis risk, behavioral control, harm reduction programs as syringe exchange, condom distribution, informational support. All these activities are first steps for changes which can further lead the client to therapeutic community. And the third one is therapeutic community, which helps to change behavioral patterns, restore social skills and values. These approaches don't rival, they complement each other as part of unified system of assistance to people with addiction. Since the launch of OST in penitentiary institutions in 2019, 1,476 convicts have received treatment. Annual figures clearly indicate the progressive increase. From 2019 and to the beginning of 2025 year, we've seen a client growth rate approximately to 201%. Throughout 2024, a total of 761 patients were receiving OST, including new clients and those who concluded treatment. Among these, 467 clients were with dangerous diseases. Specifically, it was HIV. As you see, 17%, it was about 130 patients. Co-infections with HIV and hepatitis B, only 2 patients. Co-infections of HIV, hepatitis C, 39 patients. Hepatitis C, 33%, it was 254 patients. Hepatitis B, 11 patients. Tuberculosis, 31 patients. And this big blue part, it's OST patients without recorded infectious diseases. It was 294 patients. And in 2024, 346 patients completed OST without subsequent reinitiation during the reporting period. For today, OST program is successfully being implemented at 19 places of detention in all of Ukraine, and more than 520 clients receiving OST. For today, we have 2 new sites that are on final stages of obtaining medical license. So we're looking forward that in the end of 2025, we will have more than 21 OST sites. And also, I would like to point out that one of our priorities for today and the place what we are looking for obtain medical license is to launch the OST cabinet in Kyiv SIZO, Kyiv Pretrial Detention Center, one of the largest pretrial detention centers in all Europe. This will be a serious step toward making help more accessible to people who have not yet been sentenced, but already need this treatment. Syringe exchange points and the Odessa Correctional Colony number 14 became the first institution in Ukraine to implement such a program. Since the beginning of 2023, specially organized syringe exchange points has been operating here. Inmates can anonymously and freely receive sterile syringes, napkins, condoms, everything they need to reduce any health risk. In the first 4 months of its implementation, more than 400 people used it. And the positive experience of Odessa has become an example for Strizhavka Correctional Colony number 81, where the syringe exchange point has been also implemented. Currently, during this year, we are looking to launch these points at Katerinivka Correctional Colony in Rivne region and in Solonyanska Correctional Colony. So they are preparing for implementation these points. Also, the role of peer consultants is very important in all harm reduction programs. In 2024, in Ukraine, more than 80 inmates became social workers. There are social workers in areas of HIV, tuberculosis, and harm reduction counselors. One of these consultants is Alexander. He is from Strizhavka colony. At the end of 2024, it was documented that he personally conducted screening with rapid test for 244 people, and 121 of whom, it's probably 50% of people, were referred for medical examination in timely manner, thanks to the fact that the interlocutor was one of their people. Why this peer-to-peer approach works? Because prisoners trust to their peers more. They are more open to discuss their needs and problems. Peer motivate peer. So if he can do it, so can I. And this is an effective way to motivate people to participate OST and other harm reduction programs. Strizhavka Correctional Colony was chosen by us for pilot for therapeutic colony because of significant number of prisoners with substance dependence, and the colony administration is also ready to innovate. I'll come back to. As you see, here's a map of all our OST sites, and the Strizhavka colony is over here. All of these sites, they probably serve, treat OST for 20, 30 persons, and only in Strizhavka Correctional Colony, OAT treatment receiving more than 120 persons every day. So, Strizhavka is already an example of program integration because it has the biggest OST cabinet. It has a syringe exchange and contraceptive distribution program. And here is trained medical and psychological staff that's already ready for implementation of this program. The project is still at the stage of approval and preparation. The therapeutic community program has not yet started, but we expect that a successful pilot in Strizhavka will create a similar model that already operating in other European countries. Any changes in prison system are not only about ideas, but also it about real barriers. And at present, we clearly see two key groups of challenges that we are facing right now. It's internal challenges which are related to the specific of penitentiary system, and external challenges which are related to resources and support. So about the internal challenge, security versus therapy. Maintaining the security in prisons remains a priority, while harm reduction programs require more flexibility and trust. The challenge is to find the balance between regime requirements and creating a supportive, trusting atmosphere for participants. And external challenge, it's about resources and institutional capacity. For harm reduction programs to be effective in penitentiary institutions, the appropriate conditions and facilities must be provided. Budget limitations often limit the expansion of these programs or don't allow to scale up them to required level. In this regard, additional support is needed from partners and organizations and donors to provide equipment, training materials, and any working conditions. Also, international support of harm reduction programs in penitentiary institutions requires not only national efforts but also systemic support from outside, expert advocacy, methodological support. That's why cooperation with international partners has become an important support for development of harm reduction programs in Ukrainian penitentiary system. The Pompidou Group of Council of Europe provides expert and technical support through the EuroPris projects. International consultants with experience of therapeutic community implementation in other European countries are also involved. Also, NGO involved that advocates harm reduction programs in Ukraine, and together with international and national experts, adaptation and coordination on technical issues of therapeutic community realization are being developed. In April, our working group meeting was held to present the therapeutic community concept and the implementation plan. Uh, and together with our partners, we plan to expand the coverage of those interventions that are already having a real good effect in places of detention. First of all, I'm talking about increase the number of institutions where the OST is implemented, in particular in those regions with high level of inmates with drug addictions. Also to expand the syringe exchange programs and implement accompanying interventions like informing, overdose prevention, peer-to-peer counselors, and of course continue training of medical and non-medical staff, and which is very important, with participation of regime and security staff, which takes into account the principles of harm reduction, motivational coaching, and safe interaction with people who use drugs. Moving next. And about trainings, professional trainings has already become a key tool for preparing of program expansion. We see that the institutional ability is growing thanks to systematic trainings and the involvement of international and national expertise. The Council of Europe has already organized a series of trainings involving more than 100 members of penitentiary system, medical professionals, administration, and non-medical staff. The trainings was conducted by national trainers and supported by international partners. In conclusion, I want to say that harm reduction programs in Ukrainian penitentiary facilities are gradually moving from experimentation to systematic implementation. We have already seen that even in difficult conditions, it's possible to provide continuity of medical care, reduce the risk of HIV, viral hepatitis, and increase safety inside the institutions. This is based on inter-agency cooperations, trust between partners, and shared vision of changes. We are grateful to all professionals involved in the training, implementation, and support of this program on the ground. Today, we are not talking about abstract intentions. We are talking about a real result, and this is what gives us a reason to look ahead with confidence. Thank you for your attention.
Thank you a lot, Mr. Pavlo Marchenko, for this very interesting presentation. I think it was very interesting what you highlighted as well. We will see now with the questions. No, for sure. Also very nice images you added. And for me, it was interesting to see that the OST programs you've implemented already in 19 prisons, right? In 19 institutions, you've said. So it's very, much in, let's say, progress and development in your country under difficult circumstances. And also what you mentioned, that it's still possible, the continuity of medical care in Ukraine. And it was very nice to see the different components you mentioned in the beginning as well, the harm reduction program, but also the opioid substitution therapy and therapy programs. So thanks for this presentation.
Thank you.
Now, I would like to move to a kind of discussion round and a Q&A session with our panelists, Linda Montanari, Dr. Cornelia Berger, and Pavlo Marchenko. And I've seen we have already questions in the Q&A box. So I invite again all audience to use the Q&A box and not the chat function to ask your questions, but we have one actually related directly to our Ukrainian presenter. So there's a question: do you know the percentage of inmates who use injected drugs in Ukrainian prisons? I don't know, Pavlo, if you you got the
probably
point?
it's a dynamic number. Give me a few minutes, I'll give you the maximally right answer.
Okay. Okay. We have some more questions. We can also discuss some more broader ones, but we had a question from to Linda, actually, from our Finnish participant Mario, working for the Finnish Prison and Probation Service. Could you explain a little more about the linkage to external care you mentioned? So the participant would like to know that more information regarding this. We currently struggle with too little resources, both in prison healthcare and external public healthcare. So I wonder if you would have some tips about how to engage the public healthcare in the work with prisoners.
Thank you. Thank you, Justina, and thank you, the colleague, Finnish colleague, for the question. It's not easy to answer. I see that is from the probation service, not, you say, not from the prison service. So I
both prison and probation.
Prison and probation.
Probation.
Okay. I don't think there is one single answer, and probably also my colleagues, the other speaker can complement. So first of all, this is a key issue, because if you don't link the patient to the external care, for instance, you cannot continue on treatment from when you are outside and you enter prison, and when you exit, when you are released. For instance, when we talk about, for instance, opioid agonist treatment, and we saw from the European countries that not all have this possibility to continue the treatment before entering treatment and after. That is a big problem and can be a risk also for relapse and so on. And the same for infectious diseases. Now, the solution is not easy. So I would say one of the first thing that was done, but Finland is one of the countries that has done this, was the transfer of responsibility from the Ministry of Justice to the Ministry of Health, which is not the only answer, of course. We don't have a comprehensive picture of what is done. There are some examples for the drug-related intervention and infectious diseases of, for instance, transition houses, transfer of people in specific places, and then more practical, really to try to have some active referral to the external services. If you, when this toolkit, for instance, will be released, there in several places the linkage of to care is referred to, and there are also practical examples like having, as I say, active referral means that you contact directly the specialist outside, and you write a letter for continue the treatment and so on. The other thing is having the same monitoring system, but probably you have in Finland. I'm aware I'm not responding to the question on the lack of resources and how to do this in front of lack of funding and lack of human resources, which is a big issue. I think one of the examples that there are in some countries, the more use of peer organization, peer-led organization, peer intervention that allow at least to increase the awareness, for instance, for the treatment and to continue. But also like practical thing, like yesterday was talking to a person who was in prison. She was saying now in UK, for instance, they don't release people on the Friday in order not to leave them for the weekend. So because this is a very risky thing, so they just release from Monday to Thursday, because otherwise I've encountered this situation with the person, then don't know what something happened, the services are closed, and then so having this practical instrument might be useful, but of course it's something that should be applied to all intervention. Is not easy, and I think there is not just one answer.
Perfect. Thank you, Linda. I hope there was already a satisfying answer with what you gave. So we can continue some discussions. I have another question to any speaker. So what is the provision of blood-borne virus prevention and post-exposure intervention for prison staff? Mainly frontline staff, also TB, post-exposure intervention for staff. Thank you. And we have the question from the Health Ministry of Justice in UK from Priscilla. Anyone would like to answer this? Maybe Dr. Berger, I don't know.
I just try to find that question so I can repeat it to answer it properly.
Yeah, it's in the Q&A, but I can read it out again. Could you explain a little more about
I found
the provision of blood?
Yeah.
Blood-borne virus prevention and post-exposure intervention for prison staff, mainly frontline staff, also to be post-exposure intervention for staff.
I don't know if you want, but it's not completely directly related to this, but in one of the models of care is the models of care of Milano, in the prison in Milano, where they have done a campaign for vaccination of all vaccination for HBV and HIV for all prison population and prison staff. And it was quite successful. So, of course, it's not directly, I don't know for directly the answer to this.
Yeah, it's very specific too, but you mentioned one example, yeah.
Actually, preventional, we do nothing at the moment for our staff. Of course, some elder staff still is vaccinated, depending from when and where they were born. But especially for the younger staff, there is no preventional measurements at the moment. Of course, post-exposition, they receive prophylactic treatment. Yeah, but as you had seen, the numbers within the last couple of years weren't really high. Yeah, and if there is a high risk, or if it's, for example, a patient transferred from the other prison to us and the TBC is known, we do have a special TBC cell with filter measurements and everything to take care it doesn't spread any further. Yeah, but in the past 4 years, me working there, we didn't need it. Yeah, it would be there. Yeah, but otherwise it's really post-exposition treatment as recommended.
Okay. And if we, I mean, I was thinking if we stay in the area just of staff, but now more also staff supporting detainees, prisoners, what would you say, all of you? How can prison staff and also especially non-medical prison staff personnel be better trained or involved in supporting infectious diseases and prevention and response effort?
First of all, it's trainings with medical and non-medical personnel in compliance, not
Not separate, you mean?
not separate. Yep, it's very important because every part of this person is doing their job, but sometimes don't think about prison workers, don't think about medical cases of work, and some medical workers don't think about security moments of job.
I think also in general offering training, but it should be tailored. That means we were discussing, I remember Justina in one of the meetings at European level, so to try to offer something that is very short, that is feasible, that is in the language of, not in English, of course, but in the language of the different countries and practical. So really, teaching what to do in case you have, I don't know, an overdose, in case there is an infection and so on. So that's, I think, this something that I feel is still missing. It's not
I agree.
practical also to implement, because I know that the prison staff, especially the custodial staff, they have rigid working shift and paid, so it has some financial implication. But if probably the prison administration can see the advantage of providing this training stuff to their staff, because that will also not only facilitate the knowledge for the health intervention, but also for a better management of the context. So I think that's something probably we should think more.
I definitely agree. It is needed, and also this combination of how can non-medical staff support and be more integrated, as they are having the daily and contact, and also how could they support these measures. And I know it's sometimes there is some promotion work needed to convince also to start more of these programs. Indeed, yeah.
And I think another problem to this is with the non-medical. I think the medical staff is well aware of all risks in contact due to their education and training, but the non-medical staff, I think it's slightly difficult, especially for me as a as a consultant, because data protection, medical informations, where we're not allowed to inform that a patient might be a risk factor because of a contagious disease as hepatitis C or HIV due to data protection. So our non-medical staff in prison can always, in case of insecurity or post-contact, blood contact, whatever, are always free to contact us for advice, our medical service. And of course, we have to stay along with data protection and everything. But in that case, of course, we would recommend blood checks or whatever. I think trust, another once more trust among the services, the different staff groups is very important in that case too.
Mm. Mm. Mm.
And
And anyhow, the occupational physician, knowing staff members working in a prison setting, should also, in Luxembourg, they have to see the occupational physician every 2 years, must be well aware of the necessity of the special vaccinations and everything in that case.
What is there, so that they can also inform the detainees, of course. Pavlo, you wanted to mention something?
Yeah, I wanted to answer to the question about inmates who use injected drugs. I just checked the statistics, and at the beginning of 2024, it was approximately 12% of inmates who has a history recorded of injecting drug use. But at the beginning of 2024, the penitentiary population in Ukraine was about 40,000 of inmates. And at the beginning of 2025, the estimated percentage is closer to 15%. So as to look on the statistic, it's like it increasing. But this increase is partially attributed to legislative changes allowing individuals convicted for non-violent offenses to join the armed forces of Ukraine, which has shifted the demographic profile of penitentiary population. So many people who don't use inject drugs, don't have criminal cases, they had an opportunity to join armed forces, and this a little bit changed this number.
Okay, thanks for the answer here. We have another one to Luxembourg. I don't know if you've seen it. Has the quantiferon screening been evaluated? Are you happy with it? Quite a few settings with high incident latent TB have decided against screening with quantiferon because of test limitation and different opinions regarding the efficiency of treatment of latent TB, for example. And that's a question coming from the Swedish Prison and Probation, from Axel.
So far, I do not have the numbers for all the quantiferon screenings available at the moment. That's Piet Braquet, the chief infectiologist, we would have to refer to. That's another reason why I mentioned Piet, who is, I'm sorry, not available today, is mentioned at the end of the presentation for contact. For the treatment for latent tuberculosis along the newest recommendations from 2024, we do not have numbers yet. My impression, taking care of them in daily business, is we get convinced to start the treatment. They start the treatment, and I think the numbers not completing the treatments will be pretty disappointing from my personal impression at the moment within the past year, due to short stay, and we see them again at readmission with non-completed treatment or in acceptance for, as I told before, several months of treatment without any clinical symptomology. But facts, numbers, I do not have yet at the moment. So far we do the screening on admission with quantiferone in all patients, and all patients in parallel get a chest X-ray. So we double check. For example, in our detentional institution, we only do the X-ray, and in case of we only do the quantiferone, and in case of a positive quantiferone, we complete it with an X-ray. But of course, at the moment, our best practice is the double check. And of course, as told before, we see and examine all patients within the first 24 hours. So I examine every patient, I do an auscultation, everything. I ask them for any symptomology that might occur with a TBC or any other contagious disease. So, of course, by this, actually, it would be a triple check.
Checking, indeed. But it's very impressive what you did. I don't think that it's done everywhere, so it's probably a good example coming from Luxembourg. The number of checks you do, and also the screenings, and also in the first 24 hours. So it's very interesting to see. Okay, let me see if we have another question. I really was thinking of one for if we look a bit more towards the future. And that's to all of you, actually. Where do you see the greatest opportunities for innovation or reform in the way European prison systems tackle infectious diseases in the next 5 to 10 years? So what do you think could be done, or would be opportunities to reduce the number?
As for Ukraine, it's very important digital health integration that already operates in civil civil healthcare, but also it's very important for person taken into custody just to be your medical documents, your previous examinations to be also with you. So that's also I didn't tell in my presentation, but it's also one of the ways we are looking forward to implement. Telemedicine also.
Thank you.
So in the case of the agencies, I don't know if the participant, so we change our mandate. It's one of the key words of our mandate for the future is preparedness. So the first thing is try to be prepared to new challenges, new threats, which means reinforcing, first of all, the evidence that we have. So the data, the monitoring system, analyzing the models that exist and how they work, because I'm, for instance, aware of 2 evaluation of transfer of responsibility for Ministry of Health. This is like a more broader level from Minister Justin to Minister of Health, so probably extending these 2. And then also working at the local level and with some best practice examples, some models that can be transferred to other contexts. We have Luxembourg now, but also some cases Ukraine. So proposing the models and how this practically can be transferred. So that means also promoting exchange between different professionals. I don't know if at the national level, but also at a local level, and I think I can see our mandate a bit around these lines and be attentive to what new threats can involve. We see this, for instance, the increase of injection of stimulants. So what will happen in prison regarding this? Try to be careful what in other settings happen and what can happen there, and what are the solutions also in other closed setting, and what in prison can be done as well.
Thanks you, Linda. Good recommendations. Sounds good. Thank you. Let me see. I don't know if you would like to add something, Dr. Cornelia Berger. Otherwise, I have a very specific question to you. It is referred to the annual screening campaign, point of care test. Could you give us some more information about this?
Yeah, we used to do the point of care test, but for admissions, but it's been exchanged by the admission check, blood check in general. What we still do is we do point of care tests on patients known for infectious diseases treated as HIV and hepatitis, to annual when they are known for continuing drug injection. Because of course, when they have high risk factors for reinfection, and they only get a blood check on admission and maybe during a hepatitis C, that's the best example. Yeah, they get a hepatitis C treatment, 3 months, treatment's done. We do a follow-up after 3-6 months. The no more virus detectable, treatments completed. Yeah, and they're known for continuing their drug abuse. We do an annual check on them because they have a very high risk for reinfection and all the consequences by this. Yeah. But anyhow, for example, in Luxembourg, in parallel, due to equivalence with outside prison, as long as they're under our supervision, we offer them, of course, healthcare programs, same as outside, with health checkup every 1-2 years, depending on their age. For example, I do a chronic geriatric disease program for patients older than 50 years old. So it's very complex, but for those young ones treated before, known for continuing their drug abuse, we do this test once a year. So in case they do have a reinfection, as told before, 1 out of 10 tested in a year, we find them as early as possible. If they're not contacting, if they trust us, if they contact us, if they say, oh, I started again, I shared my syringe or whatever. Okay, come on, let's get it checked. Yeah.
Thank you.
You're welcome.
Time is flying. I can't believe it. It's already almost 4 o'clock. I think we need to wrap up now and let this webinar come to an end. If there's something you would like to mention, all the three of you, towards the end, please say it now.
To thank you, everyone.
Thank you.
Yeah, thank you for your attention. And in case of any further questions, as this whole webinar will be shared and recorded, the email addresses at the end of my presentation, don't hesitate to contact us for any further questions.
Thank you. Really appreciate that you're available also after this event. We would like to thank you all again. And as said, the presentations will be shared. We will also share some recordings on our webpage. And I would like to ask our audience now to fill in our evaluation form. It's very important for us that you evaluate also our online events. So please, please, please check out this QR code. We are grateful and say thank you for your participation. I hope to see you next time in one of our events, either it's in person or online. And again, a big thank you and applause to our to our panel. Thank you a lot.